Hello and welcome to this education program for pre-hospital practitioners and emergency department staff on ambulance patient handover. This program was developed by PHECC, the Pre-Hospital Emergency Care Council, to support the implementation of the emergency medicine program's ambulance patient handover protocol. This protocol describes a standardized national system for the integrated handover of care of patients transported by ambulance to the emergency department. The protocol is intended for use by pre-hospital emergency care practitioners and ED nurses and doctors involved in the reception and handover of ambulance-borne patients. The patient's journey begins in the community with the onset of either injury or illness. A neatly packaged patient arriving into an emergency department on a stretcher doesn't always capture the devastation of high-energy trauma, the smells of illness, the patient's living conditions or social supports. Patients' clinical conditions also change en route to hospital, so a clear picture of the scene and the journey is a crucial part of patient assessment. Both national and international evidence and experience highlight the need for a good system for patient handover. Healthcare personnel need to be skilled at both giving information and receiving information. It's 7:30 on a Tuesday morning. Rose, a 74-year-old lady, becomes short of breath before breakfast and calls her daughter for help. Elsewhere, Sam and Marek are busy with repairs to an outhouse. Morning handover in the nearby emergency department is ending. The night staff are going home and the day staff are allocated their responsibilities for the day.
Ambulance, please. Yes, my mum, she can't breathe.
Relax there for a second. When you get you an oxygen mask, that will help you breathe easier.
What's after happening here?
What's this person's name?
Carl, he's started seizing. Will you pull over, please?
Control from Delta 54, priority message, wish to give an ash ice message, over.
Okay guys, Arden, you're on resus today. Emma, you're on ambulance triage today.
Clinical handover refers to the transfer of information from one healthcare provider to another, when either a patient has a change of location of care and/or when the care of or responsibility for that patient shifts from one provider to another. There is strong evidence in the literature that a good structured handover improves patient care and improves the working relationship amongst healthcare staff. The reverse is unfortunately true. Serious adverse outcomes for patients are frequently associated with poor handover. Poor handover greatly affects staff morale and performance. We've seen the nurses and the pre-hospital practitioners do their pre-shift checks. Ash ice is a mnemonic used by pre-hospital practitioners to pre-alert the receiving emergency department, and the IMIST AMBO mnemonic is used for patient handover. Their advantage is that they allow the concise relay of information. Information is given in a structured way, which makes both giving the message and hearing the message easier and reduces interruptions. IMIST AMBO is a new mnemonic originally devised by the Ambulance Service of New South Wales in Australia to allow for structured handover and to improve communication. Key components of it include good eye contact and a break for questions between the IMIST component and the AMBO component. The crew pre-alert the local emergency department of Sam's arrival using the ash ice mnemonic. A stands for age. S is for the patient's sex. H is for the history of the event. I stands for the injury or illness. C is the current clinical condition of the patient, and E is for estimated time of arrival. A good ash ice message is clear, concise, and conveys the clinical concern for the patient. The staff nurse receiving the information on Sam informs the clinical nurse manager and senior doctor of the details of the ash ice message. The rhesus team is activated and the rhesus team leader is clearly identified. Each hospital should identify their own method of identifying the rhesus lead, be that with a bib, a gown, a lanyard, an armband or a badge.
Okay, guys, what's going to happen is we've been put on pre-alert by the ambulance control. We've got a 34-year-old patient coming in. I think he's fallen about 3 metres, he's got head injuries, he's seizing. So when he comes in, he's going to stay on the ambulance stretcher. We're going to get our IMIST handover on the ambulance stretcher, and only then are we going to move him over onto our stretcher. I want you to do your ABCDE assessment, feed back to me, we'll make a plan of what we're going to do, and then I'm going to get a full handover from the crew, because I'll be more relaxed and better able to listen then. Sounds okay? Yeah, brilliant.
The team leader has explained that there will be a 2-stage handover, an initial short version of IMIST. It includes identification of the pre-hospital practitioner, the rhesus team leader and the patient. This handover occurs while the patient is still on the ambulance stretcher. It should take about 20 seconds. It is almost like a news headline. That is, it is short, snappy and catches the listener's attention.
How are you? Who's the team leader?
I'm team lead, Niamh Collins, emergency consultant.
Hi, I'm Carl, I'm advanced paramedic.
Can we keep the patient on the stretcher until we do the IMIST handover, and then we'll move him over onto our trolley and start our assessment.
Okay, this is Sam, he's a 34-year-old male. He had a fall from a ladder, height was approximately 3 metres. He had a head injury on scene, took a seizure in the ambulance en route to hospital. His GCS is 3 now and we controlled the seizure in the ambulance. Okay.
Okay, what did you give?
10 milligrams of midazolam buccal.
Okay, guys, let's get him over here onto the bed.
The patient is then moved to the rhesus trolley and the rhesus team proceed with their ABCDE assessment. It is important that patient registration is begun at this stage. As the patient is unable to go to reception, the administration staff should come to the patient. Once the team leader is happy that no immediate intervention is needed, then they relax a little and are better placed to actively listen. Active listening is the single most important factor in handover. The person listening needs to be focused, uninterrupted and able to hear. The crew can then give a full IMIST AMBO handover and invite the team leader to ask questions.
I'm now better able to listen, so can you give me a full handover, please?
Yeah, no problem. Okay, this is Sam, 34-year-old male. He fell off a ladder, approximately a 3-metre fall. He presented on scene with a GCS of 14.
Okay.
He had a head laceration, a partial thickness burn to his left arm, a laceration to his lower right leg, which was controlled with direct pressure. En route to the hospital, he took a seizure.
Okay.
He is now GCS of 3, resps of 20, pulse was 120 and regular. BP was 160 over 80.
Yeah.
Blood sugars have been 8.4 throughout.
Yeah.
We treated, controlled the seizure with 10 milligrams of midazolam buccal, and we have a line in as well. He's had 500 mils of normal saline.
Was there a lot of blood loss on scene?
With the lower limb wound, there was a fair bit, but it was controlled with direct pressure.
Okay, all right. And how long did the seizure last?
Approximately 2 minutes.
Okay, great.
Okay.
Yeah.
Okay, any other things? He's no known medical allergies. He's not on any medications at the moment. And the bystander said it was just a mechanical fall. He was blowtorching a felt roof and overstretched, and the ladder slipped out from underneath him.
Okay, so the bystander wasn't aware of any chest pain, any dizziness,
Wasn't
anything
complaining
that would
of
have
anything.
caused the fall?
No.
No. All right. Do we know if there's family coming in?
We don't know. There was just himself and his workmate.
Okay. All right. That's great. Thanks for that.
Okay, thank you.
It is at this stage in the handover, when the patient has physically moved onto an ED chair or trolley, that the handover is fully complete. This is the time that is entered on the patient care report. The PCR is then signed by one of the ED staff. If delays greater than 20 minutes occur in handover, then the pre-hospital practitioner documents the reasons for the delay in the additional information box. The 2 reasons for delay are either A. Ongoing clinical care of the patient, or B. Delay in verbal or physical handover. You saw the paramedics use the IMIST AMBO mnemonic to guide their handover. Let's look at that in more detail now. I is for identification of staff and can include name, service and clinical grade and the patient. M is for the mechanism of injury or the medical complaint. I refers to the injuries sustained or to other important information relating to the medical condition. S is the patient's clinical signs, and T refers to both the treatment given and whether the patient's condition was getting better or worse. It is recommended that the pre-hospital practitioners and ED staff maintain good eye contact during this handover. A pause should then occur for questions on this information. Then the AMBO information is relayed. A stands for allergies. M is for the patient's medications. B is for background medical history, and O is for other important information such as safety concerns or social circumstances. Rose has become increasingly short of breath over the last few days. The medications that her GP gave just weren't helping. She calls her daughter for help, and together they decide to call the ambulance. She's seen by an advanced paramedic crew who assess her, initiate treatment and transport her to the local emergency department. They determine that her clinical status is serious, non-life-threatening, and do not feel that pre-alerting the ED is necessary. They mentally prepare their handover using the IMIST AMBO mnemonic en route. They enter the emergency department and proceed to the ambulance reception area to give handover. This area needs to be clearly visible in the ED. It should allow for the confidential communication of patient information and protect patient dignity. There should be infection control facilities available and an area for crews to write up their notes. The ambulance triage nurse has many responsibilities. They need to ensure that they are identifiable, check the communications center, check ambulance reception area, ensure infection control facilities are available. Each department can select their own method of identifying the ambulance triage nurse. Suggestions include a lanyard, a badge, an armband, or a bib. It is also recommended that they write the name of the ambulance triage on a board beside the ambulance reception area.
Hi, how are you doing? I'm Emma, I'm the ambulance triage nurse today.
I'm Bridget, advanced paramedic. This is Rose, she's 72 years of age. She has COPD and she's had increasing cough and dyspnea over the last 2 days. When we arrived at the scene, she had a respiratory of 30, her SATs were 88%, and she had bilateral wheeze. So we gave her 5 milligrams of salbutamol nebulized.
Okay, just the one salbutamol, was it?
Yeah, that's right. She's allergic to penicillin, she's on salbutamol and Combivent at home. She was admitted here 8 weeks ago again with exacerbation of COPD. She lives alone, but she has good support from her daughter, and her daughter's on the way in at the moment.
Okay. She's not on any home oxygen or anything?
No.
Okay, so we'll move this patient into treatment room 2. Is that okay?
Great, thank you.
Okay.
Responsibility for the patient changes from the pre-hospital practitioner to the ED once verbal handover is complete. The handover process is only complete, though, when verbal handover is complete and the patient has physically moved from the ambulance chair or stretcher to either an ED trolley, chair or waiting area. Both the pre-hospital practitioner and receiving ED staff member agree on this time, and this is when the handover time is completed on the patient care report by the pre-hospital practitioner. It is imperative that both the at destination and at handover times are completed on the patient care report. In the event of a delay in handover, responsibility for patient care rests with the emergency department. However, the pre-hospital practitioner can continue to administer care to the patient within their scope of practice in consultation with senior emergency department staff. The new ambulance patient handover protocol involves many different healthcare workers.
One of the advantages of this protocol is that it's an integrated protocol involving pre-hospital care practitioners, emergency department nurses, doctors and administrative staff.
It's an important feature of safe and effective patient care through the multidisciplinary teams to ensure that communication of patient information is done safely and effectively.
Especially in stressful environments, having a system to deliver care which includes the transfer of information, is very important because nothing gets left out.
It will provide a consistent approach, quality approach and safe approach on behalf of the patient.
PHECC is an independent body with responsibility for standards in education, training and practice in pre-hospital emergency care. We fully support this handover protocol because it is a best practice example of how different health professionals working together as a team can work to get the best outcome for their patients.